Greetings to all our distinguished consultants, my fellow co-residents. Thank you for attending today's Grand Rounds, which is entitled A Bump in the Life of a Person Living with HIV. I am Salvador A. Rivera IV, a third-year senior resident, your presenter for today. Since the introduction of highly active antiretroviral therapy, most HIV patients are now living with only mild to moderate degrees of immunodeficiency for extended periods. And patients with AIDS are now representing an increasing minority. Thus, it is becoming increasingly important to study the association between the degree and duration of immunodeficiency and the risk of cancer. In transplant recipients with prolonged immunosuppression, there is a strikingly increased risk of HPV-related carcinomas, suggesting that even modest immunosuppression, if present for a long period, can increase the risk of these cancers. Our objectives are as follows. 1. To explore a clinical approach to the diagnosis of neck mass on an HIV patient on highly active antiretroviral therapy. 2. To highlight management considerations in a patient with HIV and malignancy. And lastly, to emphasize the burden of non-AIDS related malignancies among patients living with HIV. For the general data, our patient is JT, a 58-year-old male, married, Catholic, who currently works as a farmer and resides at Angeles City, Pampanga, came in with a chief complaint of neck mass. History of the present illness started 3 months prior to consult, where the patient noticed a left lateral neck mass measuring approximately the size of a mango seed while he was taking a bath. There was no associated symptoms such as fever, cough, sore throat, toothache, gingival pain, no sensory losses, no epistaxis nor dysphagia, no voice hoarseness, no hemoptysis, no heat or cold intolerance or changes in hearing. He noticed it was gradually enlarging in size. There was no weight loss nor loss of appetite, no consult nor medications were taken or applied. Persistence of symptoms prompted consult at our institution. For the past medical history, patient is a known case of HIV on antiretroviral medication since January 9 of 2013, where he initially presented as a case of pneumocystis carinii pneumonia and oral candidiasis. Patient then was initially treated with cotrimoxazole, double strength at 800 milligrams or 160 milligram tablet, 2 tablets 3 times a day, where he completed it for 21 days before shifting it to once a day dosing, along with fluconazole 200 milligram tablet, 1 tablet once a day for 7 days. Patient was also given azithromycin 500 milligram tablet, 2 tablets weekly, accompanied by isoniazid, which he took in 300 milligram per tablet once a day for the past 6 months. He is presently maintained on lamivudine and zidovudine at 150 by 300 milligram tablet twice daily, plus efavirenz 600 milligrams 1 tablet once a day at bedtime. Patient was also screened for CMV retinitis and was negative. The rest of the past medical history of this patient is unremarkable. Family history is also unremarkable. For the personal social history, patient is a current 22-pack-year smoker who started at age 14 consuming an average of 10 sticks per day. He is a previous alcoholic beverage drinker with no history of illicit drug use nor allergies to medications. He lives in a one-story house with his wife and daughter, along with 2 pets, 1 cat, 1 dog, and has preference for chicken and fish for his diet. For the sexual history, patient is a bisexual male who has had multiple male and female partners engaging in unprotected sex. In 2011, one of his previous male sexual partners, a one-night stand, advised him to undergo HIV screening but refused. The patient later found out that his previous partner has died of pneumocystis carinii pneumonia. He is presently with his supportive wife who is HIV negative. Review of systems were Patient was seen at the outpatient department conscious coherent, not in cardiorespiratory distress with the following vital signs. Blood pressure of 110/70, pulse rate of 85 beats per minute, regular, respiratory rate of 18 cycles per minute, and a febrile at 37.2 degrees centigrade. Oxygen saturation was 98% measured at room air. Patient's weight was 43 kilos with a height of 153 centimeters, giving us a body mass index of 18.37. Physical exam of the head, eyes, ears, nose, and throat was unremarkable, except for the noted solitary mass, which measured 3 by 2 by 1 centimeters, which was solid, fixed, non-tender with non-erythematous borders, with no movement on deglutition located on the left lateral aspect of the neck, zone 2. Physical exam of the ears with otoscopic findings showed normal results. Nasal endoscopy and the rest of the physical findings of the oral cavity were all unremarkable. Laryngoscopy likewise also showed normal results. Chest physical exam was normal with negative palpable supraclavicular and axillary lymph nodes. Physical exam of the abdomen was also likewise normal. The rest of the physical exam was essentially normal. The neurologic exam of this patient was unremarkable. For the salient features of this case, we are presented with a 58-year-old male, married, bisexual, diagnosed case of HIV on antiretroviral therapy since January of 2013, who presented with a 3-month history of a lateral neck mass. A 22-pack year smoker with no hemoptysis, no difficulty of breathing, no abdominal pain, no jaundice, nor heat or cold intolerance. On physical exam, pertinent PE findings showed a left lateral neck mass which was solitary, measuring 3 by 2 by 1 centimeters, noted to be solid, fixed, non-tender with non-erythematous borders, with absence of movement on deglutition. There were no noted axillary, supraclavicular, or inguinal lymph nodes, and the rest of the physical examination findings were normal. For the approach to the diagnosis of this case, most HIV-infected patients will present with a neck mass during their illness. The differential diagnosis includes neoplasms, infections, HIV lymphadenopathy, and parotid disease. A sketchy history and a low yield from microbiological and histological testing often complicate the diagnostic process. A thorough history and examination, a CD4 count, fine needle aspiration, and open biopsies may be needed in the workup of suspicious lesions. An infectious or a malignant lesion should be suspected if it is greater than 2 to 3 centimeters, asymmetrical, unilateral, deep, and painful. Tender lymphadenopathy is usually infectious, while non-tender nodes tend to be malignant. Infectious causes of the lymphadenitis such as mycobacteria, pneumocystis, EBV, toxoplasmosis, and cat scratch disease should be excluded. Since our patient presented with a non-tender mass, we are not considering an acute infectious cause for now. Parotid enlargement mostly results from benign lymphoepithelial cysts that develop secondary to a benign lymphoproliferative disease. It is common in adults and children not on antiretroviral therapy. Benign lymphoepithelial cysts usually present as bilateral, painless parotid swellings. As previously mentioned, our patient presented with a 3-month history of a unilateral solid mass and has been on antiretroviral therapy for the past 6 years, so we can rule this out for now. Persistent generalized lymphadenopathy and HIV lymphadenopathy describe a syndrome of unexplained diffuse lymphadenopathy involving 2 or more extrainguinal sites for longer than 3 months. Up to 70% of patients infected with HIV will develop this syndrome within the first few months after seroconversion, long before any other symptoms of HIV infection appear. The lymph nodes of HIV lymphadenopathy are soft and symmetrical, distributed, and can range from 1 to 5 centimeters. Such findings are common in the head and neck locations, especially the posterior triangle. Since our patient presented with a unilateral, solid, fixed neck mass and has been ongoing antiretroviral therapy for the past 6 years, we can rule out HIV lymphadenopathy. As previously mentioned, a neoplastic process should be entertained if the mass is more than 2 to 3 centimeters, asymmetrical, unilateral, deep, fixed, hard, and non-tender as comparable to the patient's presentation.
Clinical impression, lateral neck mass left, probably malignant, HIV stage 4.
A journal entitled A Review of Carcinomas Arising in the Head and Neck Region in HIV-Positive Patients categorized head and neck malignancies into 2 broad classifications. The majority of malignancies arising in the head and neck among patients with AIDS are the virally induced AIDS-defining cancers, Kaposi sarcoma, and non-Hodgkin's lymphoma, most commonly large B-cell and plasmablastic lymphomas. However, as the HIV pandemic persists and more people are living with chronic HIV infection, the spectrum of non-AIDS defining cancer seems to be increasing. The incidence of non-AIDS defining cancers in the head and neck in patients with HIV and AIDS is similarly increasing, including squamous cell carcinoma, lymphoepithelial carcinoma of the salivary gland, nasopharyngeal carcinoma, and Merkel cell carcinoma.
Clinical impression, lateral neck mass left, probably malignant, HIV stage 4.
Patient was then referred to the service of ENT for biopsy. Results showed undifferentiated carcinoma.
For our working impression, we have nasopharyngeal cancer, HIV stage 4.
For the staging and risk assessment of our patient, based on the clinical practice guidelines for the diagnosis, treatment, and follow-up of nasopharyngeal cancer, the following ancillary procedures are to be requested. CBC and blood chemistry showed normal results. Chest X-ray done showed no evident parenchymal infiltrates. Heart is normal in size. Aorta is unremarkable. Hemidiaphragms, costophrenic sulci, and visualized bones are intact. Next CT scan showed blunting of the fossa of Rosenmuller with evidence of tumor infiltration into the parapharyngeal space on the left. Whole abdominal ultrasound showed no focal mass lesions seen. As a review of your basic gross anatomy, we first look for the fossa of Rosenmuller. The fossa of Rosenmuller is a bilateral projection of the nasopharynx just below the skull base. It is also called the lateral pharyngeal recess or simply the pharyngeal recess. The fossa is covered by nasopharyngeal mucosa and is the most common site of origin of nasopharyngeal carcinoma. On lateral view, with the picture on the right as our guide, we can see that the mass has extended to the parapharyngeal space. Next CT scan has shown no infiltration of the bony structures at the skull base or perinasal sinuses and has no intracranial extension, involvement of the cranial nerves, hypopharynx, orbit, parotid gland, or beyond the lateral surface of the lateral pterygoid muscle. Our patient presented with a unilateral lymph node of less than 6 centimeters in its greatest dimension. No distant metastasis was present on this patient. Patient is then stratified as nasopharyngeal cancer stage 3. Based on the clinical practice guidelines for the treatment of nasopharyngeal cancer, radiation therapy is the mainstay of treatment and is an essential component of curative intent treatment of non-disseminated nasopharyngeal cancer. A journal published entitled "Radiotherapy in Patients with HIV: Current Issues and Review of Literature" states that patients with HIV who have had a CD4 count greater than 200 cells per microliter is a good performance status score and who have been treated with HAART show tolerability and outcomes similar to patients without HIV. Head and neck cancers in patients with HIV should be treated accordingly to evidence-based medicine, and intensity-modulated radiotherapy is the standard of care to spare critical organs and subsequently reduce acute and late side effects. The standard agent used in concurrent chemotherapy radiotherapy is cisplatin. This provides a benefit in terms of overall survival on both local, regional, and distant control. While 3 cycles of adjuvant cisplatin 5-fluorouracil has been a standard part of many concurrent chemotherapy regimens, its benefit is uncertain and toxic effects is substantial. Carboplatin is a derivative of cisplatin. It has a similar mechanism of action but differs in terms of structure and toxicity. This agent is characterized by its ability to generate lesions in the DNA through the formation of adducts with platinum, thereby inhibiting replication and transcription and leading to cell death. A journal published entitled "Cisplatin versus Carboplatin-Based Regimens for the Treatment of Patients with Metastatic Lung Cancer: An Analysis of Veterans Health Administration Data," notes that cisplatin and carboplatin have different toxicity profiles. Cisplatin is associated with a higher rate of nausea, vomiting, and nephrotoxicity, ototoxicity. Carboplatin has a higher risk of myelosuppression and neurotoxicity. The fluoropyrimidine 5-fluorouracil is an anti-metabolite drug that is widely used for the treatment of cancer, particularly of colorectal cancer. 5-FU exerts its anti-cancer effects through the inhibition of thymidylate synthase and incorporation of its metabolites into the RNA and DNA. Modulation strategies such as co-treatment with leucorvine and methotrexate have been developed to increase the anti-cancer activity of 5-fluorouracil. The optimal treatment strategy for patients with advanced nasopharyngeal CA should be discussed in a multidisciplinary team. Radiation therapy is the mainstay of treatment and is an essential component for the curative intent treatment of non-disseminated nasopharyngeal cancer. Stage 3 and 4 are treated by RT with concurrent chemotherapy. RT is targeted to the primary tumor and adjacent regions considered at risk of microscopic spread of the tumor to both sides of the neck. The consensus is a total dose of 70 Gray units is needed for eradication of gross tumors and either 50 to 60 Gray units for elective treatment for potential risk sites. This study shows the 5-year relative survival rate for nasopharyngeal cancer. These numbers apply only to the stage of the cancer when it was first diagnosed. They do not apply later on if the cancer grows, spreads, or comes back after treatment. This journal, entitled Drug Interactions in the Treatment of Malignancy in HIV-Infected Patients, shows that the number of patients with HIV requiring treatment for malignancy is increasing worldwide. Concurrent treatment of HIV and malignancy is complicated by unpredictable drug-drug interactions, which can cause potentially life-threatening toxicities and ineffective treatment of either disease. This article aims to provide a practical approach to drug interactions and their management in this context to help deliver effective and safe treatment for both malignancy and HIV. In the treatment of patients with HIV, standard regimens include a backbone of 2 nucleoside reverse transcriptase inhibitors combined with either a non-nucleoside reverse transcriptase inhibitor, a protease inhibitor, or one of the newer class of integrase strand transfer inhibitors. For our patient is given lamivudine plus zidovudine and his non-nucleoside reverse transcriptase inhibitor is efavirenz. According to this article, the non-nucleoside reverse transcriptase inhibitors such as nevirapine and efavirenz are both substrates and inducers of cytochrome CYP3A4 and therefore are potential victims as well as perpetrators of drug-drug interactions. Cytochrome P450 induction by nevirapine and efavirenz results in an increased clearance of anti-cancer drugs metabolized by cytochrome P450. Examples are taxanes, vinca alkaloids, etoposide, and erlotinib. Conversely, protease inhibitors inhibit cytochrome P450 and can result in severe toxicity of these drugs. In line with this, anthracyclines, antimetabolites, anti-tumor antibiotics, and platinums undergo non-cytochrome P450 routes of elimination and are not susceptible to cytochrome P450 drug interaction. The patient was seen as outpatient basis with a diagnosis of nasopharyngeal cancer stage 3, HIV stage 4. Plans for the patient was to undergo radiotherapy of 35 sessions with concurrent chemotherapy of carboplatin every 21 days for 6 cycles as outpatient basis and with continuation of his antiretroviral medications. This slide shows us the patient's CD4 count prior to the concurrent chemoradiotherapy. This slide shows that the patient underwent concurrent chemoradiotherapy every 21 days for 4 cycles as outpatient basis. Radiotherapy was also completed during the second month of treatment. On follow-up, post-4th cycle chemo, patient claimed to experience 3-day history of pallor, malaise, easy fatigability. There was no noted fever, no cough, no chest pain, no orthopnea, nor PND, no abdominal pain, no melanoma, hematochezia, nor bruises. CBC on follow-up status post-4th cycle chemotherapy as outpatient basis showed pancytopenia with a hemoglobin of 60, hematocrit of 0.16, WBC count of 1.7 with a computed absolute neutrophilic count of 829, and a platelet count of 7. Patient was then advised admission. Patient at the emergency room was conscious, coherent, not in respiratory distress, with stable vital signs. On physical exam, patient was noted to have pale palpebral conjunctiva, anicteric sclera, The left lateral neck mass now measures 2 by 1 by 0.5 centimeters, well delineated, solid, fixed, non-tender, with non-hyperemic borders. The rest of the physical exam was unremarkable. Patient was then admitted as a case of chemotherapy-induced pancytopenia, nasopharyngeal cancer, status post-radiotherapy, times 35 sessions, status post 4 cycles carboplatin, HIV stage 4. Plan was to work up the patient's anemia and rule out other causes. Additional blood tests done to the patient showed normal blood chemistry results. This slide shows the summary of the patient's CBC pre-chemotherapy, post first cycle, second cycle, third cycle, and fourth cycle, which eventually led to the patient's admission. Peripheral blood smear was also done, which showed pancytopenia. For the therapeutic plans of the patient, antiretroviral medications were shifted from lamivudine-zidovudine combination to 3-in-1 combination of tenofovir, efavirenz, and lamivudine. For the pancytopenia, patient was transfused with 3 units of packed red blood cells properly typed and cross-matched. Patient was started on G-CSF 300 mg subcutaneously once a day for 3 days and started on ferrous sulfate and plus folic acid BID and erythropoietin subcutaneously 3 times a week. Once anemia is corrected and infection is ruled out, patient will be discharged and will follow up as outpatient basis. This slide shows the CBC of the patient prior to his admission and prior to discharge. Hemoglobin was corrected from 60 to 101 and hematocrit from 0.16 to 28. Going back to the journal entitled Drug Interactions in the Treatment of Malignancy in HIV-Infected Patients, the nucleoside reverse transcriptase inhibitor tenofovir disoproxil fumarate, a prodrug of the active antiviral tenofovir, has been. Going back to the journal entitled Drug Interactions in the Treatment of Malignancy in HIV-Infected Patients, the nucleoside reverse transcriptase inhibitor tenofovir disoproxil fumarate, a prodrug of the active antiviral tenofovir, has been previously recommended for the use with chemotherapy. Tenofovir is mainly renally eliminated. Co-administration with anti-cancer drugs such as cisplatin that reduce renal function or compete for active tubular secretion may increase serum concentrations of tenofovir and of other renally eliminated drugs. Therefore, the combination of tenofovir and cisplatin is potentially nephrotoxic. This slide shows the patient's treatment timeline of concurrent chemoradiotherapy in relation to his previous admission. Patient was able to finish 6 cycles of his chemotherapy. This slide shows the summary of the patient's CBC prior, post-chemo per session, prior to his admission and discharge, and after his last 2 cycles of chemotherapy. On follow-up at the oncology clinic, patient was conscious, coherent, not in respiratory distress with stable vital signs. Pertinent physical exam showed the absence of the previously noted lateral neck mass, and the rest of the physical examination findings were normal. Plan for the patient was to follow up after 6 months with repeat chest X-ray, whole abdominal ultrasound, and nasopharyngoscopy at the Department of ENT. And based on the clinical practice guidelines for nasopharyngeal cancer, follow-up for patient includes periodic examination of the nasopharynx and neck, cranial nerve function, and evaluation of systemic complaints to identify distant metastases. For T3 and T4 tumors, MRI might be used on a 6 to 12-month basis to evaluate the nasopharynx, and the base of the skull at least for the first few years after treatment. Patient also followed up at our HIV hub. Patient on follow-up was for repeat CD4 count and HIV viral load. This slide shows the repeat CD4 count and HIV viral load of the patient post-concurrent chemoradiotherapy with a result of XXX and less than 34 copies respectively. Based again on this journal entitled Management of HIV Infection in Patients with Cancer Receiving Chemotherapy, in patients with cancer, assessment of immunologic response to antiretroviral therapy using CD4 count monitoring may not be as reliable as CD4 count and be affected by many cancer or cancer treatments such as chemotherapy, interferons, and prednisone. Plans for the patient is to continue antiretroviral therapy, to start on opportunistic infection prophylaxis, which is cotrimoxazole, azithromycin, and plan is to repeat CD4 count and HIV viral load after 6 months. Patient had his follow-up last August 2019 at the IM Oncology Clinic. On physical examination, patient was conscious, coherent, not in respiratory distress, with stable vital signs. There was no palpable neck mass at the time of examination, and the rest of the physical exam was normal. Repeat chest X-ray and WAB ultrasound was still not done. Patient was advised to follow up the Department of ENT for surveillance nasopharyngoscopy. Otoscopic examination of the patient was unremarkable. Anterior rhinoscopic exam was also unremarkable. Nasal endoscopy showed no adenoids are enlarged, no masses seen at the Rosenmuller fossa, no bleeding, no lesions, no bulging of the nasopharyngeal mucosa. Examination of the oral cavity was also unremarkable. Likewise, laryngoscopy was also unremarkable at the time of examination. Examination of the head and neck showed no cervical lymphadenopathy and no masses noted at the time of examination. On that same day, patient also followed up at our HIV hub with the repeat CD4 count and HIV viral load. This slide shows the repeat CD4 count and HIV viral load of the patient, XXX and 279 copies respectively. Plans for the patient is to repeat the CD4 and viral load after 6 months and continuation on antiretroviral therapy, with also the continuation of OI medications such as cotrimoxazole and azithromycin. In summary, we have discussed the clinical approach to HIV patients who present with neck mass and the differential diagnosis based on duration and characteristics. We mentioned the prevalence of patients living with HIV worldwide, including the malignancy where it be AIDS or non-AIDS associated cancers. And lastly, we have discussed the following issues regarding treatment of nasopharyngeal cancer stage 3 in HIV-infected patients. Thank you for listening and have a good day.